this is fractures for finals. Close that down. Won't be every fracture under the sun, but it's the ones that I thought were like either you've got distinguishing features about them or like some kind of classification system that you should really know about. Obviously you can fracture anything. So it's not a comprehensive guide to every fracture everywhere, but you're not orthopedic surgeons, so it's like pretty much what you'd need to know to get through. So of the materials I've written up for you, I've got a document that's like types of fracture, which is what we're going to do within like the second half of this. And I've got one with fracture principles. So that's everything from like how it's got a bit of a recap on like bone structure, bone healing in more depth and stuff like that, investigations management and types of like how you kind of talk about fractures and stuff. So it goes into a lot more depth than the slides on here do. So would check that out, but I didn't want to kind of insult your intelligence by being like, this is the diaphysis, this is the metaphysis, etc. So I'm going to assume you're up to date with that. If like me, you hadn't seen all this in about a year, don't worry, that's fine as well. So in ways I've kind of simplified this down a little bit. I turn myself down so I can't hear myself on that. Yeah, so just to start off with fracture healing, you break it down into about 4 phases. So you've got this reactive phase to begin with, where you get like between about the injury and the first 2 days, you get this inflammatory response where a hematoma forms, a hematoma being like a big collection of red blood cells and other inflammatory cells. And then you start to get this granule tissue formation. And that leads into your reparative phase, where from that inflammation, you get all these osteoblasts and fibroblasts. They work to form the callus. And you can sort of see that happening around day 7, so the middle picture in the sequence of pictures we've got up at the top there. Obviously, that's showing pediatric, that's your humeral shaft in a kid. But the process is still like, it's shared whether you're a kid or an adult. And then in the longer term, you get the remodeling phase. So you get this initial callus formation that reunifies the bone. But as you become, as you start to use that joint again, particularly if it's one of your weight bearing joints, so your femur or your tibia, for instance, it's going to remodel based on how you're using it. And this is what I've never seen this come up in a med school multi-choice question, but I've seen them in like a few odd sites where it's like, okay, what does this law correspond to? And Wolff's law is the law describing how bone remodels based upon like the use it's getting. So if it's being used for like weight bearing, it will remodel based on like where the forces are loaded and stuff like that. And healing time generally, like, it's pretty similar for most bones, but you double it if you're talking about an adult compared to a child, if it's lower limb compared to upper limb, if it's in the diaphysis as opposed to like the ends of the bone, or if it is an open fracture. They're just all factors that can make the healing process take a bit longer. Cool. And then just a little bit more about your healing time. Kind of going on from what I was just saying then about sometimes it's longer for certain people than it is for others. These collectively are what you call Perkins rules. So if you've got any kind of diaphyseal bone, it takes about 12 weeks compared to the metaphysis, which is about 6 weeks. The tibia, that one takes the longest, just because, why did I say how because of it? Because it's got quite a rubbish blood supply, so that takes longer than most of the bones to repair if you've got a fracture there. The rough rule for how long healing is going to take in kids is their age +1 in weeks. So if you've got a 3-year-old child, that's obviously going to mean like most of the bones take about 4 weeks to heal. Rough ballpark rule. And as we said on the last slide, adults are about twice as long as kids to heal a bone, and upper limbs about half as long as a lower limb. And then 2 terms that get tossed around quite a lot is complications that you get with fracture healing is delayed union, which is where the bones fail to unify in about 1.5 times the normal time that they should. And non-union is that happening about 2 times. So delayed union, it is happening, but not quite fast enough. And non-union, we waited twice as long as we should. It's not happened at all, even if it will happen very eventually. So they're like the rough time spans that we put on those. So investigations. Again, like I'm not going into this in loads of depth because it is like, you can be as specific as you want to depending on whether the patient is someone who's had a really uncomplicated, like someone our age has fallen on the wrist, had a really uncomplicated fracture of the wrist, pretty barn door, or is it an old person and you need to go and investigate, or could there be an underlying malignancy and stuff like that? That's, yeah, very case dependent. And like, I'm going to guess you guys at this point probably have some idea about like how you would manage those, how you'd investigate those two cases quite differently if you've been looking up different things. But as a rule of thumb, for any fracture of any of your limbs, you want to x-ray in at least 2 planes, because if you only do it in one plane, obviously you might miss it, you might not get an idea of like how angulated it is, any complicating factors, particularly for x-rays where you're thinking like, do we need to go into surgery with this? You need to obviously do full blood count, blood typing and cross match, because there's always that risk of your patient, are they going to need a transfusion? Is there going to be a bleeding risk? Especially when you're looking at like femoral fractures, because they're really vascular. Surgical input, like as you're going to see as we go through a lot of these fractures, and I know like some of you, again, you'll have had like different placements before lockdown happened, so you might all be in like slightly different places with where you're at with your knowledge. So I've tried to pitch it to you as though you've not had any teaching at all, to an extent. Oh, thanks. Thank you, whoever that was. So for a lot of them, you can manage them conservatively. Some of them, if they're open fractures, obviously, are you going to have to think about plastics getting involved? If it is a fracture that's like the neurovascular integrity has been impacted upon, the neurology needs to be involved, the vascular surgery needs to be involved. I should have written vascular on there as well, because you should always, whenever you're assessing a limb, so assessment should be right up here at the top as well. Always assess the neurovascular integrity. That's really important. So do a neurological exam, check the pulses, check for your like signs of like critical limb ischemia and things like that. CT MRI. So like you don't normally do these, but if you've got a trauma patient, you're probably going to do it. If you've got a complicated case, you're probably going to do it. And if you've got an uncertain case, from the X-ray as well. So for example, subtle fractures like a stress fracture, which very often you just can't see on an X-ray, but you've got a patient who's like complaining about pain and they've been like a long distance runner, and you're thinking, is it a stress fracture? Do an MRI, because they're quite good at picking up on like really subtle injuries like that. If you're concerned that compartment syndrome might be a thing, think about doing pressure testing. And again, if you're worried there might be something like fat embolism is quite not very common, but a complication that's worth noting with fractures, consider doing like Doppler scans, ultrasound duplex scans, DEXA scans if you're thinking is there osteoporosis or osteopenia. And with any open fracture with this communication with the outside world, think about giving empirical antibiotics, and think about giving a tetanus booster. And again, like remember, we just got a range of a fracture. Could be something that's quite simple and conservatively manageable, or could it be that someone's coming in from a road traffic accident and it's a trauma case? We're not going like deep into like ATLS principles and stuff like that, because that is a whole nother lecture, and it's kind of more a little bit beyond the scope of finals, if I remember rightly. But again, that's like, if you really want to read into all that side of things for like managing fractures of someone who's been rushed into A&E, then that could always be done in another lecture. So that's an option for future too. Cool. So yeah, simple things with fracture management. We have what you call the 4 R's. So to begin with, resuscitate your patient. So that kind of covers, again, like that, it's resuscitation as in like your A to E if you've got a patient that's coming in on a stretcher to A&E, but also just like it covers just assessing it as well, I think. So you do an A to E quickly on any patient that you see, whether they're like just walking into A&E or they're coming in on a stretcher. So assess things like, does it have neurovascular integrity? Is it an open or closed fracture? Does it look like visibly deformed? Are there other associated injuries? And then you're going to try and reduce the fracture. So whether this is like something that you're doing in the field, or you've got a patient that's coming to hospital and you've got x-rays in front of you or whatever, you want to try and restore that anatomical alignment. Ideally do this with like appropriate painkillers, because obviously the patient probably is in a lot of pain and this isn't going to make it any better. It might be that it already roughly is. It could be like non-displaced and non-deformed. If so, great, makes your management a lot easier. Or it could be that you need to apply traction. Does it need to be done surgically? Like, whole range of options for this. But you need to like consider again, like, if those vessels and nerves weren't damaged in the first place, however you're restoring that joint, that anatomical alignment, pay like a lot of consideration to the structures that are around it. So for instance, in the humerus, like the radius runs right down the radial groove, so like always be careful with that and things. And then restriction, so that's just about once you've got it into place, whatever means you've done that by, whether it was like traction or surgery, you need to immobilize it for some period of time. And you want to make sure that any casts that you use, if you're using casts, so there's a few examples we're going to go through where that is the management, make sure they're non-circumferential, because of the way that fractures are going to heal, like with that callus formation, you tend to get an associated, like the soft tissues around it are going to swell as well. So the circumference of your affected limb, arm, leg, whatever, is going to go bigger. And then you've got a risk of compartment syndrome if you're like casting that in. And you want to ensure you've got what you call actual stability as well. So that's just saying, like, if you've got a sling on your patient, for instance, it's just keeping the arm secure in place and not kind of hanging out and going everywhere and potentially like destabilizing itself again. Yeah. And then with rehabilitation, so that's like looking forward to the long term. So if you're discharging your patient, do you need to discharge them with crutches or in a wheelchair? Are they going to need physio to regain mobility of that joint? Do you need to consider thromboprophylaxis, especially if it's a patient, like an older patient who's going to be immobile for longer? Should you counsel them on complications such as fat embolus or compartment syndrome, or what to look for if like the problem's not getting better and things like that? Cool. So like the way to describe fractures, quite simply, well, there's a few different sets of how we're going to describe fractures, which we're going to be going through today. And you can find all these quite good, like if you go on like Geeky Medics and stuff for like actual, okay, here's an x-ray, it's an OSCE, how do I describe a fracture? I mean, you're more likely to get, if it's an x-ray, obviously it's going to be like chest or abdomen, something more commonly, but they do like to sometimes throw in like a wrist or something there. So obviously, like, say what type of fracture it is, which is what we're going through in the next few slides. So location, so as in like which bone, and if it's a long bone, is it in the diaphysis, metaphysis, or epiphysis? Is it one of your carpals? Is it one of your tarsals? They quite like those. Comment on whether it's angulated. So angulation sort of refers to, you can see it quite nicely in the pictures that are like just on the left there. So it's sort of saying like, if these are two bone fragments here and you've got like a hinge, is it hinged away at all? And it could be that it's angulated and not displaced. It could be that it's like displaced and angulated, but you talk about it like as though that's kind of like an axis point is the best way I can describe it. Is it rotated at all? So obviously you're not going to see the rotation particularly well unless you can identify your bony landmarks and be like, okay, that shouldn't be there. Like that malleolus isn't where it's meant to be or something like that. Or if you've got the x-ray in two different planes, which often, again, they'll give you one in like a lateral and one in an AP view. And has there been any, so displacement is when you lose that alignment. So it's displaced like laterally, medially, or whatever. And has there been any shortening? So has it kind of displaced and then gone upwards a little bit? Or is there any lengthening? Has there like, it's not as common to see lengthening, but usually you see like a nice little sort of little gap. So you could say it appears lengthened, but you're usually just going to say it appears shortened in your x-ray. And there's quite a nice image that I put in the notes again that you'll get sent out after this, which sort of has like the one on the last slide, but like in a little bit more depth, which explains what I was on about. So if you can try and get the poly V open. No, we're not going to that yet. Again, you can do it by your phone and stuff, so I'll load the thing now that shows you how to do that. This is my first time messing about with this, so please bear with me. I share. Cool. Okay, we've got 1 or 2, I think. Again, with some of these, there's not per se like a wrong or a right answer. I just kind of want to get some of your thoughts going. This is quite fun to watch, actually, isn't it? Right. So I think we've got about all of you. So, right. So for this one, this, according to Google, is a transverse. I'd agree you could probably argue it's a little bit oblique, because if you look at the one that's in the, well, it's in the lateral view, the one on the left, it kind of has a little bit that's going down like that. So I think the thing I always hated about x-rays, and this is probably why I would never try and run the kind of session that the radiologists teach where they're like, okay, this is this and that's that, because I think they're always quite open to debate, and I don't think there's ever like a clear-cut answer. But this one technically is transverse, because you'd argue it's going like sort of perpendicular to the joint line. So if it was oblique, you'd probably want it to be like a little more obviously oblique, if that makes sense. So that was quite a simple one. And if you want like an example of an oblique, do I have one I can show you? Well, again, there's a picture in the handouts which you guys won't have got yet, because I did use some of the pictures in this, and I didn't want you to have it and then kind of cheat. But yeah, so obviously oblique is just going to be a little bit more like that. Spiral, we'll get onto the difference with like the spiral and the oblique in a minute, because they can be quite hard to tell. Is it segmental, comminuted, or compound? Is this working okay? Right. Can you guys hear me, or are we having issues with my internet? Right, okay. Sorry guys, I'm not sure what's going on. Can't wait responses from the poll. Right, try that. There we go, nice one. So if you can't hear me at all, please just put something on the chat, because I can see the chat. I just can't, like, my laptop just sometimes seems to go, I'm trying to watch myself on my laptop to see if we have tech difficulties. Sorry for this. Because we've been having a couple of internet issues where I live this week, to put it lightly. Right, okay. So yeah, so this one is an example of a comminuted fracture. So if you were looking at comminuted, it's basically just saying that you've got more than 2 little sections of fracture broken up, and it tends to happen when you've got like kind of a crush injury or polytrauma, like someone's been in like a bit of a nasty accident that isn't like they've been bashed around from a few different angles, is what I'm trying to say. It's not like a cut and dry, okay, they've been hit there, they've fallen on their outstretched hand. Or it occurs more commonly if you've got, say, like an older person that's got like an osteoporotic bone, and then they fall in it, and because it's brittle in a few areas, it sort of just crumbles when they fall onto it. So segmental is referring to a bone that's got like, say it would be broken there, and it results in like at least, I suppose you'd technically say like 3 fragments from at least 2 different cut-off points. And compound is just an open fracture, but I kind of put that one in as an option because I used to get comminuted and compound mixed up, or complex and compound. But yeah, compound would be meaning that it's somehow communicating with the outside world. Right. Let's give this a go. Yes. Right, I'm going to assume you just all straight go for spiral. Yeah, that is a spiral fracture. So like that one obviously pretty obvious because you can kind of see the shading in the back where it shows a little bit different. You'll see if you Google spiral fracture and oblique fracture, they all do look pretty similar. So I guess again, it just shows the importance of making sure that you get at least 2 dimensions in your X-ray and stuff when you do them. It's the next one. Yeah, cool. This one, there's a few of you still going for it. This one's a green stick fracture. So the two that you tend to get in multiple choice questions that are pediatric are your buccal and your green stick fracture, just because of the way they happen. They're more likely to happen in like pediatric bones because they're softer and they're more deformable. So what's happening here, if you imagine it like a stuffed twig when you snap it and it sort of breaks on one side and not on the other, and then it bows over a little bit, that's a green stick fracture. So it's just like an incomplete shaft fracture. So it starts to then bow over to the opposite side that's stayed intact. Obviously like common in the wrist and the femur and stuff like that. Is it letting you do it? Do we have internet drop out again? Yeah, I know. Right, so this one, I'm not gonna say it's a trick one. You could get away with all 3, depending on exactly if you probably like went away and did an MRI and really checked, okay, is this happening on the epiphyseal growth plate? Buccal and torus are the same kind of thing. It's just a different name for a buccal fracture. So both would have been right. You'll see it noted as a buccal more often, but if you see torus, don't freak out. It just means the same thing. So basically what's happening is, if you can see on like that picture there, sorry, I probably should get this up. It's like stress forces are kind of causing it to bulge out. So it kind of looks as though the bone's sort of like telescoping in on itself a little bit. And this can happen quite a lot at the growth plate because it is a little bit more squishy. And if it obviously disrupts the growth plate, then it's a Salter-Harris fracture, because a Salter-Harris fracture is just a fracture where the growth plate is, either the fracture goes through the growth plate or it involves the growth plate somehow, which we're going to talk about in a bit as well. So next one. This might be your last one, actually, I'm not sure. Give it a go. Yeah, I'll take it. No one's putting the other options because correct, that is a stress fracture. So stress fracture, basically, we've kind of touched on it just before. Basically, you've got someone who's doing a lot of repetitive activity and load bearing. So it classically happens in people that are like training to run marathons, or like all of a sudden take on like a manual labor job or something like that. And they start to get these like very small hairline fractures. And they don't, whereas like obviously a classic shaft break will present with like very sudden onset pain and immobility. Very often they might just kind of start to have quite late presenting pain from this wear and tear. And by the time you do an x-ray, it might already appear quite calloused. So actually, like, a lot of what you can see there, because you can sort of see that like opaque line, my mouse won't work, but the opaque line where the arrows are pointing, that's like the start of callus formation. And because this has been going on so long that it is starting to fix itself, and that's kind of how you pick up on it when you see it on x-ray, if you're going to see anything at all. So it could just be something that doesn't actually require any, you see it's tiny, you're probably not going to need to fix it surgically, but you're going to need to have some period of immobilization to let it actually do that callus formation and fix itself properly. And you probably need to like recommend some lifestyle changes as well. These kind of people probably shouldn't be continuing to run on it. Some people do. Right. Oh no, we have one more. I tell a lie. Yeah, so this one is an avulsion fracture. So fissure fracture, we've got a picture of back in the slides that I'll show you in a minute, but you don't really tend to see those very often. An avulsion fracture is just where you've got a syndesmosis, so a bit of tissue. For anyone who was like me and just couldn't remember terms from first and second year, it's where you've got a bit of soft tissue that's attaching a bone to another bone. And for whatever reason, injury happens and it pulls a little bit of bone away. So like here, like obviously, like you can see it's happened in the finger, happens quite a lot in the foot. And yeah, happens quite a lot around like around your knee as well. So anyway, you've kind of got like little plateaus or like your malleoli or whatever. Sometimes they're really, really tiny. So if you ever get like quizzes that have fractures on and you really can't see the fracture, like pay real close attention to the joint integrity. And if you can see that like tiny little a little bit of dark grey, it could be a bigger fragment, it could be a much smaller fragment, but very often like you really can't see them at all. Yeah, that's your quiz. Right, back to it. So got to have like a little bit more on like the fracture basics to do, and then we'll get on to like specific fracture types. And if you guys don't mind, I tried to set it up as a poll EV, but I just thought it'd be easier to do it as quiz through the chat, so we'll continue doing it that way. That way. Cool. Right, again, so yeah, if you do have any confusion about any of those kinds, that image there, like it had most of the kinds we talked about. There's no pictures I could find where it had everything, but in the material I've tried to break down all the different types and like give you an x-ray example of what they look like. But they're just quite good terms for like, they're just like the first thing, like just say what you see. Is it oblique? Is it transverse? Is it spiral? Is it a mixture of a few? Because it can be. So compound fractures. You obviously, like I was saying, in the management and investigation side of things, you need to like always kind of manage these with some kind of degree of surgery, like whether that's just plastics and like covering the wound, or are you going to have to do open reduction and internal fixation. Always remember to cover with like empirical antibiotics. It's been exposed to the outside world. Give someone a tetanus booster, because you can get your tetanus spores into like, they come in and they attack the exposed nerve endings and stuff. That's pretty nasty. Yeah, I'm trying to think what else to say. These are a combined problem for orthopedics and plastics, and you classify them with what you call the Gustillo-Anderson classification. So simplified version of that is just like, if it's type 1, it's a low energy wound and it's going to be less than 1 centimeter in length, and it's going to be pretty clean as well. So like quite a simple laceration. If it's type 2, it's going to be just above 1 centimeter, still quite clean, but have some soft tissue damage. And if it's type 3, it's going to be much bigger, with quite extensive damage. So you can then break type 3 down into 3 subtypes based on like how adequate the tissue coverage is. So if it's got adequate tissue coverage, it's just saying like there's not, like flaps of skin haven't been cut away, or the tissue that is kind of hanging there isn't necrotic. And this is more like a thing for plastics to like distinguish how much they've got to work with. But if it's type A, adequate soft tissue coverage. Type B, there's some loss and a little bit of exposed bone, and they're going to need some grafting. or type C is when you've got like associated vascular injury. Obviously you're going to have to get vascular surgery like involved as well, and it can become a bit of a limb critical thing, which isn't great. And then your Salter-Harris fractures. So these are, again, like in pediatrics, because it's kids that need the growth plate to continue having that bone growth. And you get it quite a lot if you are getting those buccal fractures. The easy way to remember like your Salter-Harris fractures, I know this comes up on PassMed quite a lot, but they don't have this kind of little an acronym, I don't think. It's SALT-C or SALT-ER. So type 1 is going straight through the growth plate, like goes straight through but doesn't actually interrupt it. 2 goes like through it, well, like along it and above it. Type 3 goes kind of along it and below it, so L for lower. Type 4 goes through everything, so like through your epiphysis and a little bit of your diaphysis as well. And type 5 is crush, so like it is through the growth plate but it's like crushing it, so it could be a buccal fracture. And types 3 to 5 likely to require surgery because of where they're sitting, and type 5 is the most likely to be associated with disruption of the growth plate. In fact, I don't really, looking at it, I'm not sure how it wouldn't disrupt the growth plate. Other ones can, but type 5 is always going to disrupt the growth plate, so that's like your nice little rule for remembering how to distinguish those. Cool. Right, if you guys can be active in the chat for me, can someone try and describe that for me? Or just like ping some ideas to me. Say what you're seeing. Is it displaced? Is it, what joint is it? What are you seeing?
Oh.
Or speak, that's fine. If we get no engagement on this, then I'll just keep moving through them. Yeah, cool. So when we talk about displacement, you're talking about how is the distal fragment displaced from the proximal fragment. So yeah. And I'm not going to tell you you're wrong or right again. Downward, so you could posterior displacement, I guess. Just because, again, I'm probably not the expert to teach you on like, okay, that's like, I could probably say that's right and someone else would disagree with me on like the descriptions of things. It's just kind of to get you having a think about like how are you describing it. So like obviously like that one is displaced and you'd probably just say, okay, it's displaced by like, I don't know, if you had a scale, you could say it's displaced by like roughly this many centimeters or millimeters. And you can't see like whether it's like displaced like this way or that way because you don't have the lateral form as well, but nice one. So yeah, this is obviously a clavicle fracture. So you classify your clavicle fractures with what you call the Ullmann classification, which you can see in the picture there. And you tend to base it based on whether like it's in like microphone, it's in thirds of the clavicle. So like you've got your medial, your middle and your lateral third. They're most commonly going to happen in the middle third, just because that's like the most insecure bit of the clavicle, if you will. Like it's obviously like it doesn't really have any attachments. It's not particularly surrounded by anything. So about 75% are going to happen in group 1. And these are like, they're normally pretty stable, but they're quite obviously deformed. They tend to stick up out the skin quite a bit. And what you tend to get is like your lateral segment's going to go down with the weight of the arm, and your like medial segment's going to go up with the weight of your sternocleidomastoid. And then group 2, your lateral third are like the second most common, and group 3, like that medial third, is your like least common type. So yeah, someone's put in the chat, it's your, yeah, thanks Kate, it's the Ullmann classification. So I haven't written that on the slides, but I can go and change that when I put them back out. So yeah, with that, most of them you're going to manage the way you can see in the picture there, so just by slinging it, because most of these, they're not happening at like high energy. It's usually just when like someone's fallen over, like fallen outstretched hand, that happens. If you're going to manage it surgically, usually like you can usually just like manually what's the word I'm looking for, manually like put it back to the alignment you're meant to have, and then secure it with like a collar and cuff or a sling. If you do have to manage it surgically, you might use a plate, but you're not going to usually like keep those plates in because it's quite a superficial bone, so it's quite unsightly and it's quite uncomfortable for patients. Cool. And generally, like if you're considering surgery, it's either if it's like, yeah, it's really comminuted, or after about 2-3 months the patient isn't showing any signs of improvement. So someone describe this one for me then, or a few of you describe it. Yeah, I'll give you that. So I could say you can see it's going to be obviously visibly shortened because you've got your distal segment is like sitting above your proximal segment. You've got a bit of angulation there as well, while you've also got displacement, so it's displaced and angulated. And we're looking at a humeral shaft. So humeral shaft fractures, again, don't want to make the chart that big. Pretty common, but what you've really got to watch out for these is radial nerve damage, which gives you that characteristic, like your wrist drop and then like your loss along the radial distribution of your sensation. And this is quite characteristic in something called a Holstein-Lewis fracture, where like the distal third of your humerus, so like down here, gets fractured and the radial nerve gets entrapped. And again, like you want to get your AP and your lateral x-rays of this, just to check like which way is it rotated, is it angulated or whatever. This, like your conservative management is your what you call a functional humeral brace. So you can see a picture of that in the bottom left there, making sure like you're stabilizing the elbow, so you're stabilizing the joint below. And if you are going to manage it surgically, if it's like a polytrauma, or if there's been like it's a severely osteoporotic bone and you don't think it's going to heal just in a cast itself, think about doing like intramedullary nailing, which you can see like in a picture on the x-ray there. Come on, move along. Yep. So what are we seeing here, guys? I'll take the name of the fracture. Anybody? Yeah, nice one. Yeah, so scaphoid fractures, I know I've not really chosen the best picture, it's a bit of a grainy one. A little bit like with the stress fractures and stuff, they don't really like, because it's such a small bone, well, I know it's the biggest of your carpals, but they don't present very obviously, because you get that overlap of the carpals anyway, so you can be looking at it on an x-ray and it just kind of looks a little bit vague. And obviously the med school love giving grainy x-rays. Why? I don't know. But a scaphoid fracture is, yeah, it's your most common of the carpal fractures, and it's one that you really want to like, you don't want to misdiagnose it because you've got quite a high risk of avascular necrosis, just because the blood supply to the scaphoid, it's like one of the branches of your radial artery flowing in obviously what we refer to as retrograde flow. So that supply is cut off quite easily disrupted by a fracture. And if you leave it for long enough, because a lot of people do, they'll just fall in their hand, it won't get picked up on an x-ray, it'll get left, and then it just can lead to degenerative wrist disease. So you don't want to miss it. And your way of not missing it is to, instead of just doing like an AP and a lateral, you get what you call a scaphoid series of x-rays. So you take it, I think it's from at least 3 angles, and it just means that you're not going to miss it. Obviously, like you want to try and do an MRI and stuff as well, just to have that like higher level of detail. And it presents characteristic oxy stuff again, with that sudden onset of pain in your anatomical snuff box, pain upon feeling your scaphoid tubercle, which is like obviously down here below the thumb, and on telescoping the thumb, which is that movement, like just rotation and moving the thumb around. And you're going to want to manage it by immobilizing it in plaster and using what you call a thumb spica splint. So the thumb spica splint, if you've never seen one before, is what you've got in the picture on the bottom left there. If you are going to have to screw it, you can use what you call percutaneous variable pitch screws. I can't say I've ever like either seen that surgery or seen it come up in a question, but I have seen thumb stick splint come up in something before. Right, what can we see in the red arrow, and what do we think we can see in the blue arrow? Anybody? It is fat pad displacement. Do we know the name of the sign? So again, like some of you may have come across this, some of you like, don't worry if you like, never heard of that in my life. So yeah, the red is showing us a fracture of the head of the radius, and then the blue is showing you what you call sail sign, which is just like, it's fat pad displacement from effusion. So here we go. So sail sign with radial head fracture. Obviously, yeah, I've tried to keep the slides quite bare minimum, so this isn't going to be everything to do with radial head fractures. Again, there's going to be like a bit more in the handout I've got for you if you want like some more specific bits of epidemiology and stuff. I just kind of try to keep it simple because this is like pretty image heavy as it is. But they're just like the distinguishing factors, because most fractures at the end of the day, like they're going to present with like sudden pain and stuff, aren't they? They're quite similar. So sail sign, you'll see it on that lateral x-ray, and it's like effusion of the elbow and then elevating the anterior fat pad, which if you go back, you can kind of see that just behind the elbow there. And you're going to distinguish it based on what you call the Mason criteria. So type 1, if it's like not displaced much, so by less than about 2 millimeters, you probably just treat it with like a sling for about a week, and then you try and get the patient to get it moving. Type 2, so you can treat it very similarly, but if there's what you call mechanical blocks, if the patient is struggling to move it, you might want to consider doing an open reduction, an internal fixation. For anyone who doesn't know, by the way, if you see like the abbreviation ORIF, that's just open reduction, internal fixation. And type 3, if it's like, again, comminuted, quite complex, if it's displaced a lot, you're always going to manage it surgically, and like put it back together with like screws. Consider also like you might have to take the radial head out and do a replacement. So the image that I've got on the left there is just like a graphic showing like how you might consider screwing them back together, but there was another image I found that had like whole replacement of the radial head as well, because if it's just really broken, we can do that quite easily. Cool. So who can tell me what we're seeing on the left and what we're seeing on the right, and which is which? Anyone? Yep, so one of them's a Colles. Yes, nice. So if the right one's Colles, it's the left green stick. Not green stick, no, the left, yeah, so nice. Left is Smith's and right is Colles. The Colles on the right, I tried to get one that wasn't like too obvious, because some of them, like the Smiths that you can see over there, is like really obviously like over to one side. But the Colles is like a little bit more subtle. So your difference is Colles is the one that's going backwards like that, Smith's going forwards. There are fancier terms for that, which I've written down below, which I can never just look off the top of my head, but you guys obviously for finals are going to have to like know, okay, that one's volar and that one's dorsal. So you tend to get them when you have someone falling on an outstretched hand. I've got quite a funny picture in the next one that shows you like the different mechanisms of how they happen. But yeah, so someone falls in an outstretched hand and they end up with what you call dinner fork deformity, where, I mean, yeah, if you want to get a fork and kind of remember it that way, but I just tend to remember it more as like that versus that. So dinner fork deformity is Colles, and garden fork deformity, where it's going forwards, is Smith's. But the better way of saying that is dorsal displacement of the distal radius if it's Colles, or if it's Smith's, it's volar or palmar displacement, or angulation of the distal radius. So they're both just different types of distal radial fracture. Yeah. Again, like your management is pretty much as for like any kind of shaft fracture, like you like manage it surgically if you need to, manage it conservatively if you can, manipulate it back into shape, and obviously like put like a whole wrist cast on those. Yeah, so this is a quite funny picture that I've found. I don't know who falls like that, but apparently if you fall like that, that's the way that you're going to get a characteristic Smith's fracture. Collies are more common just because obviously like everyone puts their hands out when they're falling just to kind of try and like save themselves, but you can kind of just like see here like whether the force mechanisms are going to like be pushing the end of the radius and how that happens. Cool. So next one, what can we see? And obviously it's a knee for anyone who just wants to go, it's a knee. Mm-hmm. So if you're looking on the left hand side of the image, you can see like obviously we've got on the right, we've got like nice bit of continuity, follow it over to the left, and all of a sudden you've got disruption of the tibial plateau. So yeah, it's a tibial plateau fracture. Most of them don't, again, look quite as obvious as that. But you tend to get this sort of like very sudden onset pain because it's disrupting the articulation of the joint. And if you leave it for a long time, you can get like quite rapid degeneration of the knee joint. So you want to get it dealt with quite quickly, and you want to like really protect your articular surface before like you basically sentencing someone to have a knee replacement. So yeah, you want to either get it protected with what you call a hinged knee brace if you can manage it conservatively, or if it's kind of hinged, I don't know why I put, oh sorry, I was reading my own writing wrong. Yeah, so hinged knee brace, or consider doing open reduction internal fixation and then putting a hinged knee brace on it if it's a little bit complicated. If it is very complicated, so again you've got that polytrauma, it's comminuted, there's a lot of associated soft tissue damage, you might want to consider external fixation. So that's what we're showing with like the fancy contraption around the lower leg in the picture in the bottom right, which sometimes you see with like hip fractures as well. You don't tend to see those like cradle type devices with like things in the upper arm so much. And then that hinged knee brace is going to be on for about 8 to 12 weeks again, because as we were talking about earlier, tibia, the tibia doesn't really heal very quickly just because it's got a really rubbish blood supply for whatever reason. So yeah, so it tends to present with like this sudden onset pain, patient can't weight bear, the knee swells, they get what you call lipohemarthrosis, so where you get like fat and whatever else swelling with blood and things. And yeah, tenderness on either the medial or the lateral aspects, depending on which side you've got your fracture happening on. So tell me what you're seeing here. And this is just a couple of examples of like the same type of fracture. It is a spiral, yeah. Yeah, so we've actually got like, if you look across, you've got from left to right, you've got a spiral, a transverse, and then another spiral of the femur. So anyone who has done like a little bit of like pre-hospital medical type stuff before will know that the femur is something that you don't really want to be bleeding from, because it is the longest bone in your body and probably the most vascular bone as well, because it's one of the key sites of hematopoiesis. So if you have a fracture of your femur, very often it happens secondary to like, again, like some high impact trauma, but you can lose up to about 1.5 liters of blood from it. So it's usually like coming in, going to happen in a patient who's coming into A&E. So you want to quite quickly make sure you've got like traction on it or whatever to try and stabilize it. And to classify it, you use what you call the Winquist and Hansen classification. This wasn't something that I'd ever seen come up in lectures before, but it was just something that I've thrown in there for interest because I found it when I've been preparing these slides for you guys. But you can see like the breakdown of the types in there. So again, manage it according to ATLS principles. And the normal way that you're going to manage it surgically, at least once you've got like your A to E done and you've sorted out any bleeding or like other nasty things that are going on, consider using what you call an antegrade medullary nail. So you can see that in the X-ray. Obviously, this is like a comminuted tibial femoral fracture that we've got going on here, and they've got that intramedullary nail, so a nail that's going right up through the intramedullary cavity, and some nails just fixing that in place there at the bottom. And obviously you do external fixation if it's like really unstable and you're struggling to get a hold of it. Yeah. How about what have we got going on? If we call it A, B, and C from left to right, what have we got going on in A, B, and C? Have a little think. So we can see, obviously it's the upper end of the femur. Yep, so it's neck of femur, but they're different types of neck of femur. So one of them is intertrochanteric. B would be intertrochanteric one. Yep. Yeah, so roughly that. So like your first one is an intracapsular, because that's happening, although you can't visualize the capsule in the X-ray, it's within the capsule. Then you've got your two extracapsular ones, assuming you're not, like, some classifications break it down into like all different like mad amounts of classification, but for the level of finals, just keep it as like intra, extra, and like your subtypes of extra, which we'll go through in a second. But if it's like above the line of like the greater and lesser trochanters, it's intracapsular. If it's below, then it's going to be an extracapsular one. And intracapsular, it's like it's going along that line between your greater trochanter and your lesser trochanter, which you can see in the middle image there. And if it is a subtrochanteric, it's happening basically like just sort of at the top of the like the shaft of the femur, so to speak, but below the line of the trochanters, which you can see on the right there, sorry. So yeah, hip fractures, like I was saying, you'd break them down into intracapsular or extracapsular, and you can see like on both the images that I've got up there, kind of like the lines of like where that's happening, and there's like odd like descriptions they'll give to them, like intertrochanteric with subtrochanteric extension, this, that, and the other, just like for like this it's important to recognize like which is which based on like identifying of an X-ray and then your management, because you manage each one of them differently, and there's a few factors that will change your management as well. Obviously you can still have a fracture of the femoral head itself, and another name for an intracapsular is just the transcervical, because cervical meaning neck and like the neck of the femur. Yep, hopefully you guys are roughly familiar with your anatomy of the hip, but just keep it quite basic for like if you're struggling to remember stuff because everyone forgets stuff at finals, just keep it as simple as that for the sake of this. So for classifying them, you use what's called the Garden classification. The only bearing that's like really going to have on anything is that the blood supply is disrupted with types 3 and 4. So it's just going off whether like if it's types 1 and 2, it's displaced. If it's types 3 and 4, it's non-displaced. So as you can see with like, if we go back to the image, the one that we've got, your subtrochanteric one obviously is displaced. It's like over on the right hand side there. So that would be like a type 3 or a type 4, whereas your other two, you could argue they might be a type, without really breaking them down, aren't necessarily displaced. And then yeah, breaking it down over whether it's like a complete fracture of the hip. So is it like totally cutting through the neck, or is it just a little bit? And like, is the displacement partial or is it completely displaced? So yeah, your general management, if you've got an intracapsular, it's obviously like there's exceptions to this. So if you've got a patient that's like older, even if you've got an undisplaced one, you might still consider doing a hemiarthroplasty if they aren't fit for cannulated hip screws. But if it's a simple undisplaced intercapsular fracture, use cannulated hip screws, which are shown in the image on the very top there. Like I'm really sorry I can't speak today. They are what cannulated hip screws look like. And if it's displaced, then because you tend to get like with intercapsular fractures that are like your Garden classification 3 or 4, they're displaced, you get like that disrupted your blood supply to the hip, which is your profunda femoris, if I remembered that right. The medial circumflex artery, again, it's one of your, like with the blood supply to the scaphoid, it's one of your, like your arteries. It's just like prone to getting disturbed with fracture. So if you disrupt the blood supply, there's a risk of avascular necrosis. So just for like the sake of ease, you're going to do a hip replacement. So you're going to like totally replace it if it's a young person who you know is going to get the benefit of having the whole thing replaced, and they're going to be able to recover it from as well, because it's a bigger operation than a hemiarthroplasty, having just a little bit of it replaced. So if it's an old person who you're thinking like, yeah, we need to replace it, but in all honesty, they're probably just going to not be as mobile as they used to be, just consider like replacing part of the joint. And if it's extracapsular, you can break down your management into whether it's intertrochanteric, and then you'd use dynamic hip screws, which are shown in like the middle image, the one that's kind of like looks like it's sort of got a toothbrush on the end. And if it's subtrochanteric, you're going to use an intramedullary device. So that's shown obviously like in the bottom left. And again, like if in doubt, if you've got like any kind of vascular compromise, you just do a hip replacement. But that's like the general rule, and you'll get it's a like really easy exam question to ask you like, okay, here's an x-ray, what would the management be for like this particular fracture? So just know your types and know like the rough corresponding management for them. So I think, yeah, last but not least, what have we got going on here? Yeah, nice. So fracture of the distal fibula. There is, yeah, someone's right. There is on the right hand side one at least. I don't know about the left hand side one because I can't see the chat. Yeah, so the right hand side one is showing a fracture, like it's an ankle fracture on both the malleoli. So you can see like on the your tibial malleolus there, you've got a fracture as well. So very often with like a fracture of the fibula, you're going to get an accompanying one on the other side, depending on your mechanism of injury. So an ankle fracture is just generally we like, it's a generic term used to talk about any fracture of either of the malleoli. So it could be like a fibular one in isolation, it could be tibial, so yeah, your medial or your lateral, or it could be a combination of the two. And you classify it based on the Weber classification. So you can see that in the picture that I've included over in like the top right there. And actually, if you go back to the x-rays, I've included it like I'd set them up as A, B, and C. So if you're going through this on your own at another time, you've got a Weber's A on the left, Weber's B in the middle, and a Weber's C on the right hand side there. So if it's A, it's at the height of the syndesmosis. So again, that soft tissue that's joining the bone to bone. If it's type A is below the syndesmosis, type B is at the level of it, and type C is above it and very often involving it as well. So because of the position of it, C is like your most unstable, and also like your most proximal, and that's the one that you're definitely going to have to like manage surgically. So obviously, like to manage it, reduce it, usually like as with every fracture, use your 4R principles, and like once you've put it into alignment, you're probably going to put it in what you call a below knee back slab, which you can see in the picture over on like the bottom right there. And you can probably get away with conservative management with types A and B. You're going to use surgical management for some type Bs if you need to, and most type Cs because they're not stable enough just to heal on their own. And yeah, other fun facts for you. Yeah, I don't think I've got any more fun facts for you about those. Cool, yeah. That's everything. Sorry if I just seem a little bit like today, but hopefully that was like a nice sort of whistle stop tour minus my internet going off partway through. Yeah, has anyone got any questions, guys? Thank you.